of Caiti and Pescara Hospital in Italy. And he's going to share with us the latest evidence on the performance of NIPT or cell-free DNA in pregnancies with vanishing twin. Thank you so much, Francesco.
Thank you, Asma. Thank you for the invitation. Thank you all this incredible number of people who are connected. It's almost 800 at the moment while I'm watching the screen. Yeah, so this is a webinar on NIPT in twin pregnancy, but we will start with something which is not appropriate to twin pregnancy, but is something similar. And during this talk, we will go through the different aspects of vanishing twins, which is an incredibly more common phenomenon than what we think, going through the outcome association, the biochemical screening, so the use of an NIPT and by using with particular clinical scenarios. So let's start with the definition. So what is a vanishing twin? So practically speaking, clinically speaking, is a spontaneous reduction from a twin to a singleton pregnancy, which usually occur in the early first trimester of pregnancy. The prevalence of this phenomenon is higher than what we think, is about 15 to 35%. I would say that most of the studies actually were conducted in IVF pregnancy because, of course, the prevalence of this condition is strictly dependent upon the gestational time, so the gestational age at which we scan people. And of course, we know that in pregnancy from IVF, we used to scan these women in early gestation compared to spontaneously conceived pregnancy. And of course, is also related to the population analyzed. We know that there is a higher risk of this condition in specific population, and I will go through that in a few minutes. So how can we diagnose? Of course, in order to diagnose vanishing twins, we have to have at least 2 ultrasound assessment. So it is a result, so diagnosis of vanishing twins is a result of a longitudinal examination in which we see a viable gestational sac with the embryo, with of course a heartbeat, and the other one in which of course there is no cardiac activity. So this is an inconsistent definition because we have several definitions for vanishing twin. In such condition, we can just see an empty gestational sac. In other condition, we can just see a gestational sac without the yolk sac. In other, we can see the fetal pole without heart activity. So there is no homogeneous and objective definition of this phenomenon, but of course it is related to fetal development. And there is also a classification which has been proposed a few years ago according to 2 different types. So it's quite simple, to be honest. In type 1, in which we have the loss of the twin occurs in a relatively early gestational age, in which we can see just 1 embryo and 1 gestational sac with no embryo, or just your sac, of course. And in type 2, in which the embryo is present, so the embryo of the non-vital, so the non-viable pregnancy is present, but with no heart activity. So the ultrasound definition, of course, is variable according to the type of, so the gestational age at which we scan people, and of course, according to the interval between gestational age scan and the occurrence of fetal loss. Why does this phenomenon occurs? So there are several and different theories. Of course, one of the most accepted is a presence of aneuploidy. So especially those coming from rare autosomal trisomy. Other one comes from the presence of inappropriate implantation site, placental crowding. So we know that in studies from IVF, higher the number of embryo implanted, higher the risk is for vanishing twin syndrome, intrauterine bleeding, chronic maternal disease. Of course, because most of these studies were conducted on IVF pregnancy, the quality of the embryo transfer with the higher risk of having vanishing twin phenomenon in moderate compared to high quality embryo transfer. And so the other question, this is a clinical question. So before entering the heart of the presentation, so that is vanishing twin syndrome associated with adverse pregnancy outcome. And this is a controversial answer because we have several studies actually reporting a controversial association between this condition and adverse pregnancy outcome. This lack of evidence, so this lack of robust evidence is not dependent upon the quality of the studies, but rather of their inclusion criteria, because some of them included pregnancy with death occurring in the 2nd trimester or also in the 3rd trimester. Some of them did not include monoclonic pregnancy. Most of them did not look at different developmental stages of vanishing twin syndrome. And of course, there are different outcome definitions. So what we know is that there is no strict association per se between vanishing twin syndrome and adverse pregnancy outcome, but some studies report that. And which are the adverse outcome associated with vanishing twin syndrome? The presence of preterm birth, perinatal loss, fetal growth restriction or small for gestational age, and pre-eclampsia. And if we want to give a biological, a pathophysiological explanation for the occurrence of this adverse outcome in pregnancy vanishing twins, we might claim different hypotheses. This third placental circulation actually occurring after the death of one twin. The theory of placental crowding, I already mentioned that. So there are several studies conducted on IVF pregnancy which report the higher risk of fetal restriction or spontaneous loss or preterm birth with an increased number of embryo transfer. And of course, another theory, another potential explanation might be the chronic inflammation coming from the release of necrotic tissue or prostaglandins from the diseases fetuses. Of course, we have not a clear explanation, but just some hypotheses. But we know that, of course, if there is a controversial association between vanishing twins syndrome phenomenon and the occurrence of adverse pregnancy outcome, we know that this condition might significantly influence, or at least might influence, the first trimester screening. So we know that in most of the cases in every part of the world, when we assess the risk for aneuploidy and we start from the conventionally reported combined test, we used to measure the CRL, taking the neutral translucency, or of course, if you want to go more deep into details, we can assess the ductus venosus at tricuspid regurgitation, and of course, assess the biochemical markers, which are the free beta ICG and a PAP-A. So now the question is, what is the influence of vanishing twins on first trimester screening tests? Of course, we do not have any influence on nuchal translucency in most of the cases, of course, but there are studies which report that altered biochemical levels in pregnancy after vanishing twins, especially higher levels of PAP-A, and also in most, if not all, studies, a higher level of beta HCG. Which are the possible explanation, the possible biological connection between these findings and vanishing twins is the presence of residual persistent trophoblastic activity, which so the trophoblast may continue to produce these analytes, or alternatively, the presence of aneuploidy, because we know that in a significant proportion of cases, the vanishing twins may be the result of the diseased fetus due to a common trisomy, so a common chromosomal anomalies, but in most of the cases, a rare autosomal trisomy, which may potentially be the clinical implication of this influence of vanishing twin syndrome on biochemical markers. So if we look at increased PAP-A levels, it may potentially increase the false negative results for trisomy 18 and 13. Of course, I would say that most, if not all cases with trisomy 18 and 13, they show anomaly to ultrasound assessment. This is quite common. This is obviously common. And of course, regarding beta ICG levels, they might be increased in some autosomal trisomy, and we know that the increased beta ICG level may be potentially associated with adverse perinatal outcome. But there is a study, so if we want to mention a study, which is the last one, if I remember well, on the association between the vanishing twin syndrome phenomenon and the combined screening test, is one from the Fetal Medicine Foundation, which actually they do not report a previously reported increased level of beta ICG, but they confer the increased levels of PAP-A after vanishing twin syndrome. And of course, they reported that this increase in biochemical markers in PAP-A was inversely related to the gestational age at testing and the interval between the IUD, so the perinatal loss, and the testing. So they also reported the diagnostic performance of combined tests when using the PAP-A alone compared to PAP-A beta ICG, which was 86% compared to 91%. And the authors actually suggested that when we face with the diagnosed pregnancy with vanishing twin syndrome, it may be actually hypothesized to use nuchal translucency plus maternal age plus just beta ICG in order to reduce the potential confounding factor coming from the assessment of the PAP-A. Of course, we do not have big number about false positive results, so this is just a theory. But we know now that we are in the era of cfDNA-based technique. We actually have revolution the way in which we approach the first trimester screening. We know, so this is a result of the meta-analysis I just showed trisomy 21, because I know that the other speakers would extensively talk about that. We know the diagnostic performance and detection rate for the common trisomy is very high. It's more than 99% with a very low false positive rate and a very low, so with a very high negative predictive value. But we know that in some condition, we might have false positive results. And false positive results, of course, I'm not a geneticist, but I will try to make things simple. It might be from the affected fetus, so the fetus might be actually affected. It might be to placental mosaicism, which means, of course, that the genetic anomaly might be actually hidden in some cell from the placenta. We might have these abnormal cfDNA results coming from maternal conditions such as uterine fibroids. There is a reported association between big fibroids and positive result as cfDNA analysis. Of course, it might be due to technical failure, and of course, in such cases, it is much rare in maternal malignancies, but also in vanishing twins. And the biological, so the rationale between the false positive test results from the vanishing twins is that the release of DNA from the deceased fetus may lead to, of course, false positive results and NIPT. The issue is that, yes, as I highlighted at the beginning of the presentation, the NIPT, so the cfDNA-based technique, are actually very reliable in detecting chromosomal anomalies, but they cannot determine the source of DNA first, and at least the conventional one, not the last one, they cannot determine additional fetal haplotypes associated with abnormal result. So in this case, the presence of the vanishing twins may potentially lead to inaccurate test results, potentially increasing the number of unnecessary invasive. And this is, so I haven't done a systematic assessment of all the international guidelines. Some of them, actually, they do not support the use of cfDNA analysis in case a vanishing twins is prospectively diagnosed. And of course, NHS, because asthma works in the UK, and the American College, which says that the risk of abnormal tests actually is high, and that we should consider, in this case, diagnostic test. So what is the evidence? So is vanishing twins significantly affect the robustness of cfDNA analysis, or is this one just a spurious association? In order to do that, actually I retrieve a systematic review, and we are doing something similar together with asthma. There are not so many studies looking at this topic, actually a very few of them, 7 to 9, and the problem with these studies, actually, they are not similar. So they are very heterogeneous as regards the inclusion criteria, with most of them including high-risk population, fetus with anomaly. They do not actually accurately report gestational age at presumed fetal loss. They do not mention onchorionicity. They do not mention fetal fraction, as most importantly, they do not look, at least most of them, if not all, just one, if I remember well, they do not report the presumed interval between the loss and cfDNA analysis, which I will tell you in a second. It might be of significant importance when we applied such tests to a pregnancy with vanishing twins. So what is the combined evidence? Of course, not so robust, because the number of papers published at this stage are not so many. For trisomy 21 in pregnancy with vanishing twins, the rate of positive result at cfDNA analysis is about 2%. And in in 25% of these cases, the positive result was confirmed. So the confirmation occurred only in 1/4 of cases with positive result of cfDNA analysis in the setting of a vanishing twin. Regarding trisomy, the negative predictive value, of course, was very high. Regarding trisomy 18, 1% of positive test result is cfDNA, which is, if you remember, the value reported for singleton pregnancy is much higher compared to what reported in the normal population of singleton pregnancy without vanishing twins. So in pregnancy with positive results for trisomy 18, only 50% of cases, for 50% of them, were confirmed. And of course, the negative predictive value was also high. When talking about trisomy 13, 0.5%, we had 0.5% of false positive result when applied to vanishing twin, and it was not confirmed in any of the cases. Of course, in this case, the number of included cases was very, very small to draw a robust conclusion. And in autosomal trisomy, which are by far the most common causes of early miscarriage and potential, of course, in this case of vanishing twin phenomenon, the positive test result was about 3%. And in none of the cases included in these ongoing studies we were actually are conducted with asthma, it was not confirmed in any of the cases. We might presume that all these cases came from placental mosaicism. And in sex chromosomal problem, also very few cases included, and 0.5% of, I don't know who is drawing on the screen. 0.5% was just one case of monosomy X, and it was not confirmed in, so it was confirmed in just one case of triple X, which was not confirmed. So there are very few number. We actually testify that compared to standard application on a cfDNA based technique, we have a higher positive test results in cases with vanishing twins, which can potentially range for 2 to 12%. And this leads to higher false positive rates, lower positive predictive value, and the majority of positive tests in the setting of the vanishing twins were not confirmed after invasive procedure. Of course, in most of the cases in which they were confirmed, they were likely from the deceased twins. Which are the main determinants of false positive results? So which factors should we take into account when we want to potentially apply cfDNA-based technique to pregnancy with a confirmed vanishing twin? The timing at perinatal loss, fetal loss, the type of vanishing twin, and the potential interval between the loss and cfDNA analysis. So why it is important, the gestational age at loss? Because we know that in the few studies, there are not so many, the mean duration of the persistence of the DNA from the deceased twins was in average 8 weeks. And in most of the cases was low, the influence, the potential false positive result was lower when the test was done after 14 weeks. And there was a study by China in which the authors actually repeated the test after 15 weeks of gestation in the 9% cases, of course, after a positive result, a cfDNA analysis, and in 9% of them, the result was not confirmed. So I repeat, when they had a positive test result at the time at the 11 to 14 week scan, then they repeat it again after 15 weeks, and in 9% of cases, the NIPT result was negative. And also the type of vanishing twins might have a potential implication or in affecting the rate of false positive results. So we know this in type 1, in which they do not recognize any embryo, the fetal loss occur in early gestation, there is a potential reduced release of fetal DNA, a faster clearance, a reduced false positive results. So in type 1 compared to type 2, potentially the influence of vanishing twins in affecting the result from cfDNA is lower compared to type 2. How can we prospectively apply this in clinical practice? So we have two different clinical scenarios. So in case one, in the first case, in which we recognize that there is a vanishing twins, we might choose upon, of course, in this condition, should be done a discussion with the genetist. We can estimate a nucleotide base just upon the risk on nuchal translucency. But of course, we know that in this case, the detection rate is not as high as when we combine it, and is about 75%. We can decide to perform combined screening tests, actually ideally using only beta ICG, or if we use PAPE, of course, considering that we might have a false positive results by using a standard combined test, or of course, offer cfDNA analysis after 14 to 15 weeks of gestation in order to reduce the potential confounders of the DNA from the deceased fetuses in affecting this condition. Of course, or alternatively use the new technique which are based upon the single nucleotide polymorphism, which of course in this case they can recognize different fetal haplotypes in dizygotic pregnancy. There is another clinical scenario in which, of course, we have a positive result. This is not the topic of the presentation, but so when we have a false positive results, so should we go and look for a potential presence of vanishing twins? So clinically, I would just say, of course, that we should go to invasive, but potentially we know that the recent single nucleotide polymorphism cfDNA-based technique can detect. So can detect fetal haplotypes from dizygotic twins, and which are the possible clinical applications. I just, of course, draw some example. One can be when we have negative NIPT test following an initial positive test. The other one, when we have inconsistencies between ultrasounds and NIPT results, when we have questionable mosaicism chimerism, or when we have women with unexplained bleeding or spotting. So this is actually something that we can discuss. There is no robust evidence to do that at the moment. And I think this is something that we might consider with further research. So to sum up, and I hope to not have bored you, especially at this time, so vanishing twin syndrome is a relatively common phenomenon. Also, the association between clinical outcome is controversial. what we actually, the evidence is that it can affect biochemical analytes when we perform combined tests, and this can also lead to increased risk of false positive result when we apply cfDNA based technique. We have different strategies, which I think I explained in a decent way, and there is no robust evidence of which option we should go for. Thank you very much indeed. Thank you, Asma, for the invitation, and thank you for all the audience to listening me.